have our next critical conversation here, and this is going to be with Doug Elwell, who's the Chief Executive Officer of HMA and my boss, and Theresa Eagleson, who's in charge of Healthcare and Family Services. So I'm particularly happy now to introduce Doug Elwell. Doug?
Hey, good afternoon. Thank you. Continue to enjoy your lunches. I have this great task. I think everybody would like to ask Theresa Eagleson a series of questions, but I get to. And so I think I'll just take a couple of seconds. Theresa Eagleson is an incredible person who's been serving the state for more than 20 years in dealing with vulnerable populations and how we can do better and how we can do better in healthcare. Incredible boss. She was my boss. She did an incredible job. Extraordinarily amount of resilience and ability to just keep going and just keep fighting the good fight. I see Kelly Cunningham. I see Keith Flores. I see just a whole series of people who are just really doing great work. Jim Parker. Just Illinois is blessed to have maybe not enough people, but the people they have are just absolutely fantastic. So Theresa, how are you doing today?
I'm doing very well, Doug, and it's a good thing I was nice to you when you worked at the department, since you get to ask me these questions in front of all these folks today.
I don't remember the nice part. Let me think about that. Weren't you the one who said we have to upgrade and told me I had to get Kelly to take the job? Anyway, that was part of, okay. Hey, just I've been gone a while. What's new at HFS?
There's a lot new at HFS. We've been just moving and trying to implement a lot of new things. During the pandemic, actually, we had started a couple months before the pandemic, revisiting our strategic plan, our mission, vision, and values. And really, you probably all heard Deputy Governor Flores talk this morning, and really these are the values of the entire administration, recentering our focus around our customers, sometimes our shared customers across sister agencies. The mission, of course, of the department is around financial, physical, and mental well-being of our customers, but we share a lot of that responsibility, if you will, with our sister agencies, and really trying to, like I said, center around the customers and focus on health equity. I don't know if I should be looking at you or at the audience.
Well, look at the audience. I'll just look at you.
But we've also launched a new HFS brand, We Improve Lives, that you probably see, and we tried to be using these little backgrounds. You sometimes see us matching in meetings to remind ourselves, what we stand for and who we stand for every day. We've also, as you know, managed care, I think, is really working in this state, better serving the needs of our customers, better than the fee-for-service model did. Managed care is providing some critical resources to help patients navigate, but we want to do more of that, and really trying to push levers to improve quality and service implementation for our customers. The health equity focus, I just can't say enough about. And a lot of the big initiatives that we'll talk about that we've implemented over the past couple of years are focused there. And we're also an advertisement for the 1 o'clock session, working on an 1115 transformation waiver that our Medicaid Director, Kelly Cunningham, is going to talk about. I would also just echo your comments. I can't say enough good things about the team at HFS and actually across the whole administration. And that includes OMI, the Medicaid Innovation Office that Jim runs, and just a really good group of people. And we may not move as fast as you all want us to all the time, but we certainly are doing our best to get things done.
Okay. Well, we're coming out of the pandemic. Mm-hmm. Really difficult place to have been. A lot of work, a lot of hours. Things are now changing. What's the biggest challenge coming out of the pandemic?
Redeterminations, renewals. Our customers haven't had to renew their coverage for some of them for as much as 3 years. We have been trying to build awareness for the past year to make sure that everybody knows this is coming. I'm sure that they still don't all know this is coming, but we've implemented a multilingual omni-channel outreach campaign. I was telling someone earlier this morning, I've walked into a couple FQHCs and doctor's offices and things, and I see our QR code about ready to renew, so glad for that. But we really want to, in this state, we don't want there to be a coverage cliff. We want to make sure that everybody who's still eligible can stay enrolled, and I think that's the biggest challenge over the coming 12 months.
Okay, great. And I just want to salute you guys. My understanding is you've done a huge job in ex parte.
Oh, yes. Before the pandemic, ex parte, for those of you who aren't aware of that, means that we can find enough information electronically to renew someone without having to get them to return a form to us. And before the pandemic, we were in the low 30% range of people who we could renew that way. In the first month when we sent out the different forms, we had 51% that we could renew automatically, which is just really incredible.
Yeah, absolutely. It's great. Okay, so demand for behavioral health services during the pandemic was, off the chart, and it's a nationwide issue, not just an Illinois issue, but a nationwide issue. So where do you see opportunities to expand access?
There are so many. I think there's 2 sessions here today, right, about children's and general behavioral health care. I mean, there are workforce issues, capacity issues, but we have invested as an administration over $170 million in the behavioral health system last year. I can't remember the exact number, about $40 million this session. But really committed to connecting our customers with quality behavioral health services and really targeted intensive services at the right time to keep them out of hospitals and keep them, hopefully avoid an escalating crisis. So the governor's budget included rate increases for things like intensive outpatient, partial hospitalization, assertive community treatment, and we've also been rolling out since January our Pathways to Success model, which is, I call it enhanced services and infrastructure, focusing on kids who need intensive care coordination. And so just really trying to connect people at the right time to the right services to keep them from escalating. And even though the labor market, another announcement that we made this week, or last week, even though there are a lot of labor market challenges, we are really trying to figure out ways to, we made an announcement that there can be shared resources between mobile crisis response teams and CST teams. So that probably doesn't mean something to everybody in this room, but I think it means something to people familiar with some of these behavioral health services intensive treatment teams. So.
Great. Now you need to work on being more verbose because I'm going through the questions a little bit too quickly.
Oh, I'm sorry.
So talk about what you see as the biggest wins over the last couple of years.
Okay, well here I can be verbose. Nursing home rate reform last year. It took us, it was like a 2-year build, but something that we had been wanting to do for quite some time. We really saw it as a moral imperative, back to the putting our customers at the center and making sure our customers in Medicaid get quality care. The package that ended up passing is more accountability for facility owners, better staffed facilities, and improved safety for residents, regardless of where they reside. When we started looking at some of the data, and that's another thing about the department, is we've really tried to switch to being a lot more data informed in driving our policy decisions and recommendations. So, we wanted to do nursing home rate reform before the pandemic, kind of got sidetracked a little bit with the pandemic, but there's so many inequities, right, in some of these facilities across the state. And so this was really an equity-driven effort. We talked a lot. We probably had 50 meetings with different legislators talking about this and garnering support. And this is going to mean a better quality of life for over 45,000 Illinois Medicaid customers in nursing homes around the state. We also worked with our sister agency, the Department of Public Health, to compare staffing data. We pulled data from all kinds of places, not only the federally required assessment, but also the nursing home survey data and staffing data and all these things. We tied. The package actually ties enhanced rates, significant enhanced rates, as you get to a higher percentage of the federal Strive. Strive is a measurement of nursing home staffing, for those of you who don't know. So starting at 70% all the way up to 110% of Strive, significant money attached to every percentage increase. And we think we need to do more of those kinds of things, because then you're pushing exactly the lever, right, that you want to push to get better services to customers. Staffing is quality in a nursing home setting. And so I'm pleased to say that 3 quarters in a row now, since this was implemented, we have seen staffing. Illinois was at the absolute bottom on the federal charts, and now we've seen staffing go up 3 quarters in a row. So that's just huge for us, and we want to do more of those kinds of things, like how do we really tie reimbursement to the results we want for people.
This is a really big deal. Every state in the union is looking at nursing home reform. I know of no state that's accomplished it the way Illinois has. So it's a really big deal.
Yeah, our federal partners have been incredibly supportive on this journey. And, the team at the department, again, somebody who's not here, Andy Allison, deserves a mention, did a lot of the, former Medicaid director in a couple of states, did a lot of the number crunching, Melissa Black, who was, but we, like this really intense data-driven effort, but also, like I said, we felt it was a moral imperative to serve people better, so. And then Healthcare Transformation Collaborative, something that we started when you were at the department, or at least we envisioned. I don't know if we actually got quite started when you were there, but we decided to make some of the funding for hospitals, well, it wasn't really funding for hospitals, it was some money that was raised through the hospital assessment, plus the administration came up with some general funds money as well to really get providers, especially hospitals, at points of transition and even points of prevention, right, to connect with other providers to better serve our customers. We have about 15 funded. There have been some funded longer than others. We funded 9 Healthcare Transformation Collaboratives. Probably, I see so many familiar faces. Many of you are participating in this, and we're so grateful for your work and ideas around how to better serve Medicaid customers. And this is a program we've got about $150 million a year to spend. We have funded a lot of projects for 3, 4, 5 years to really make an intensive effort here, and then we hope to make these, the goal is to make them sustainable and come up with reimbursement methodologies and incentives that over time, as we see the results we want to see here, we change our course to fund these and to fund different approaches. So again, putting our customers at the center, looking at quality, looking how to engage people better, looking how to get people to preventive care before they end up in that hospital.
Okay, that's great. Why don't you raise your hand if you're part of one of those collaboratives?
Oh,
I can look out
great.
on the thing and I can see a number of people that I know. I see the West Side Collaborative, some South Side Collaborative people, the Safer Foundation people. It's a pretty large group of people here. Yeah,
and there's a real variety for those of you who don't know. Everything from like reentry, after someone has had a involvement with the justice system, to there's behavioral and physical health integration in Southern Illinois, and some of the service enhancements on the Northwest and South Side. So there's all kinds of different collaboratives and approaches we're testing. So thank you all for participating in that. Other highlights, I'm trying to think. We've had so many great things. Like I said, behavioral health investments, pathways to success. The budget that just passed has almost $1 billion annualized. A lot of the things aren't starting until January, but almost $1 billion in new funding to all kinds of different providers. Just really looking to try to target both services and communities where we really need to bring services to our customers.
Great. Tell us some more about this 1115 I keep hearing about, which I think is still in the comment period.
It is in the comment period. You have until June 12th to say, yay, Illinois needs this. Please say that. Kelly's going to talk about it a little more. It's really a broad, deep, we're going to ask for things related to health-related social needs for our customers. There's housing support requests in there. There's food and nutrition support requests in there. There's a 90-day pre-release enrollment in Medicaid request in there. There's some stuff to change the way we finance certain things so that we can bring in more money to some of the largest disproportionate share hospitals. So there's a lot of great requests. And right now what we need is the, advocacy to our federal partners to allow us to do this. And then we're also collecting, we want to talk to all of you about implementation once we're, kind of down that path of hopefully getting approval. So a lot of people want to know a lot of details really early on, and right now we're just like, we want to go get the conceptual funding, right? And then, there are eligibility criteria if you read the proposal that's out there. There are, other details in there, but there's a lot of implementation details, I would say, that we really have, probably at least a year to work on, and we want to do that. But right now, the main challenge is that support and getting it, to the place that we can be negotiating those operational terms.
Great. Well, I learned I will not get the initials right, as Jay knows. I never get the initials right, but HSRN is, I think, the old
HRSN.
See, I told you I wouldn't get these right because I just learned SDOH. And then they changed it. This is, I heard it.
Just don't say DISRIP.
DISRIP. Okay, I won't say that one. I probably couldn't spell it, so we're safe. I think that, I just heard in the legislative session, they talked about something really interesting for providers to think about in terms of, they said, we believe we've been adding to the healthcare provider landscape for a long time. It's not always directly to healthcare. So they talked about, a couple of years ago, we put a lot of money into housing. Mm-hmm. And that has healthcare implications. So you can't think of it as a provider. You can't think of it as, I got money. Sometimes you have to think about it, the whole system got money because it went over here. And that instead of always thinking about, well, did I get something personally? No, you've got to think about, did the ecosystem get something? Because now I can use those resources. As you're kind of looking to the future and looking at, I'm not even going to try, I'm going to stay with SDOH because I can spell that one. Now, if you're looking at those things, what are you thinking about? I know that we have the federal partners are getting more liberal about this, but I also know there's always the mechanisms of, is it actuarially sound? There's a whole bunch of complications.
Yeah, and we're thinking, like, one of the biggest things, and, we knew this, we tried even before you were with the state to get something around housing supports, because we all know, and the research shows us, right, that when somebody is stably housed, their healthcare outcomes are better. So we're very interested in that. This administration proposed in the budget, and it was passed, Home Illinois, to pay for some of the housing development and things, but then Medicaid will try to pay for some of those supports. Like if somebody's moving, they don't really need to be in a nursing home, but they don't have any place to go, that we could help connect them to both maybe budgeting support to keep them in housing, help them with things like first month's rent, help bring services on site. So those kinds of things, housing supports for all kinds of different populations, but especially people with behavioral and developmental health needs. Food nutrition, helping there's a lot of discussion out there about whether prescription food or tailored food programs, to help people. Diabetes, we know how diabetes is, I do too, right? We know how diabetes we have a really incredibly high incidence of diabetes in our population. How do we start to change the curve on that for the future so that, people are still going to get sick, but hopefully there are a lot more supports there, and it doesn't happen as quickly or as often, and they don't need to go into a nursing home, or they don't, what I mean? They don't, or they get a cancer screening sooner, those kinds of things. And it's wrapping services around people and making sure that they don't have to go 16 different places to get those services, that we can make it easier for them to access those services.
Great. So now we've got you kind of on the spot. I see there's a lot of great providers out in this thing. If you could ask the providers for something, some way that they could think differently, think about things, if you could ask them, what would you ask them for?
Think bigger. I think maybe, we need all of you. We couldn't do this without all of you, but think beyond your doors. Think about what happens when that patient or customer leaves the hospital or even the doctor's office. Think about what's next for them and how much, to us, it's about putting that customer or member at the center, and we've all had healthcare challenges, whether it's personally or with our families or, with loved ones, and we all know how hard it is at certain points in time. When you get that devastating diagnosis or when you're in a behavioral health crisis. So how can you help that customer more? And how can we help you help that customer more? Beyond just the service at the moment. That's, I think, what my ask would be.
Okay. Now, the other group, I'm looking at all our friends in managed care and saying, what would you ask from the managed care plans?
The request isn't a whole lot different, but maybe they're more on the how do we help providers do that, and where are the gaps, right, that we need to fill in to deliver those services in a more coordinated fashion. Some of it's, data and information sharing. Some of it's navigation and deploying the right kind of, care manager, if you will, or community health worker, if you will. So I don't think the request is all that different. It's kind of the angle and what, from all our various seats, how can we, do a better job together of actually making life better for that member.
That's great. I think all the managed care plans owe you a great deal because they remember the Monday meetings I used to conduct, and you've kind of made, I understand they're much nicer meetings today, and they're not as often.
Does that mean Robert's nicer than you?
Robert was always nicer than me.
We've come a long way, and I'm so glad. I've said in a lot of forums that when the pandemic hit, I was so grateful that we had built what we had built with our managed care plans, because I don't know if any of you know this, but state government's not super nimble at times. I mean, we did a fantastic job, the heroes sitting here in the front table, Dr. Ezike and Deputy Governor Flores, and a lot of people, everybody rose to that challenge, right? But as a Medicaid agency serving 3.9 million people, well, now what's 3.9 million people, we could have never implemented the detailed thing. We could have never gotten iPads into nursing homes or hospital, wings to have people communicating with their loved ones. We probably couldn't have organized, some of the food drives and things like that our health plans were able to do. And we gave them the ability to do that. instead, we suspended our quality withhold payments, and we said, go spend this, go target this money to find places to help people. And that's what they did. We approved those plans, and that's what they did. So we've come a long way from, we're not paying claims. And we want to stay there. We don't want to go back. And we just want to keep building on that foundation. So.
Okay. What else would you want to impart? This is your opportunity.
Oh my gosh, I didn't think about this. Yeah, it's just like, how can we work better together? How can we communicate better? A lot of times we hear things about, it seems adversarial, especially, we just came out of the legislative session. And that's not it just seems like it's I want this and you want that, and, we're gonna argue. Let's talk more, and let's talk constantly, like, about how can we do this better together. I mean, I think we all in this room, most of us don't do these jobs unless we're invested, right, in the same kind of things that we're talking about here. So I think, like, let's talk, let's brainstorm, let's have more of these discussions, so that and smaller, not always just me talking to you, but let's have more of these discussions and figure out how we can improve healthcare delivery, because I don't think any of us are satisfied with the way it's going right now. There's some great things happening, don't get me wrong. We've talked about a lot of them today, but we can all do better, right? So let's figure it out.
Okay.
I like to solve problems. I know every single one of you does too, right? So let's put all that brain power together and figure it out.
Okay. I'm going to ask you, and I'm now totally off script, whichever
I'm
way
totally
I would
off
be.
script too.
So we're kind of like, we're out of control. So we spend a lot of time, there's a lot of groups, we still have carve-outs in our managed care for certain populations, for certain things. We have people always advocating for more carve-outs, and we have advocates for more carve-ins. We hear about the benefit of integrated care. We also hear the benefit of looking at specialized populations. What do you see for the future of Illinois Medicaid in that realm?
I'll say on record, the department went on record, we're really unhappy about the transportation carve-out, because when you're talking about health-related social needs, especially in rural communities and some of the inner city communities, transportation is such a key factor in getting to healthcare and even health-related appointments and things. So, I mean, I see the big picture as more integration. And that means that somebody needs to be responsible, right, for total cost of care, and being able to deploy those. Always going to be not as much resources as all of us want, right? So somebody has to be in charge of that total cost of care, and being able to say, you know what, we can't get access to psychiatrists over here, so we're going to pay psychiatrists more. I'm just making this up, by the way, you know what I mean, this particular thing, but we're going to pay more for this service over here because we don't have access to it. We can't do that at the department. Everything has to be, we can have regional variations and those types of things, but it's much harder to be, as I said before, nimble. So I think our managed care partners can make some more of those decisions, and I hope that they will start doing that. Now we have a stable program. It took us a while to get to a stable program. Now we really need to talk about and start thinking about and start deploying, right, more value-based decisions. And how do we do maybe more subcapitation, transferring some of that both risk and upside and downside risk to providers who are ready, willing, and able to do that. So.
Okay.
That's where.
I just want to thank you. Again, I want to thank all the people who are here from the state or the federal government. We have a terrific group. I thank you as a taxpayer. I thank you as a member of the community who just wants to live in a community that's better than the community I live in today. So thank you very, very much.
Yeah, it's not just me, it's the entire administration and the entire HFS team. It's a great group of people, and I could never do this job without every single one of them.